So in this lecture, we're going to cover some of the basics as well as simple interrupted suture placement. And as we discussed in the lecture, your packaging actually gives you quite a bit of information. So this is going to tell you, number one, that it's a practice suture, so it's likely not sterile. Please do not use at home. It's a 4-0 in terms of the overall size of the suture itself. It tells you it's a reverse cutting needle. It's 19 millimeters and actually gives you an image of the needle itself in terms of the overall curvature of the needle, but also gives you an image of, if you were to look down the shaft of the needle, what it would look like. It also tells you it's 3/8 inch in terms of, or 3/8 of a circle. It's nylon, it's monofilament, it's non-absorbable, and it's 45 centimeters in length. So most of your sutures come between 18, 30, and 45 centimeters in length. That's very common lengths, whether you're talking operating room, urgent care, or emergency department. So I have a suture loaded here, and we're going to do this demonstration right-handed just for ease. So this is your needle driver with your suture in place, and a few things about your needle. So we discussed the swag of the needle, and that's where the suture material actually inserts into the needle itself. Please don't place your needle holder there. You will inadvertently break the suture off. Then we talk about the overall essentially arc of the needle, and you selected this needle for a reason. So therefore you want to attach the needle holder more toward the swag, but again, not on it, so that you have the entire curvature of that needle to actually use and help you with suturing this patient back together. We talk about the tip of the needle, and that's actually one of the most vulnerable points of the needle. So we never want to grab that directly with the needle driver. We would potentially bend it, and you actually can break it off. So you wouldn't want that to be a risk for a foreign body to the patient. Needle drivers themselves, we always want to ensure that the needle is at the furthest aspect of the needle driver. You would not want to have the needle toward the middle of the needle driver. The reason for that is then all of that additional space is in your way. Let me demonstrate that for you. So if I had my needle and I clamped it here, then I have to get all of this aspect of the instrument into the patient, and then I can use my needle. Much more beneficial to be as far down as we possibly can. That allows for less depth of the instrument into the patient themselves. So a simple interrupted suture, and we discussed in the lecture the rule of halves. So if this is your laceration, and let's say this is on the forearm for your patient. So we want to be approximately 3 to 10 millimeters back from either side of the wound, and we'd like to space the sutures approximately 5 millimeters apart is typically good form. Again, rule of halves. So if we look at this laceration in its entirety, if we were start to pull things together and in the center, place one suture, and then you can start to look at the other aspects of the laceration and essentially begin to divide and conquer. Always operating toward us, and ideally we don't have the instrument actually in our fingers, it's in the palm, and we're using the index finger simply to guide that range of motion, which occurs essentially at the wrist. Now, if you are a left-handed person like myself, then you are actually operating with your left hand, you actually need to put the instrument into your fingers, because otherwise you will not be able to disengage the needle. Most of your instrumentation that actually has a clamp is designed for a right-handed clinician. You want to always operate toward you whenever is possible. So again, grasping the skin, you chose the needle for a reason, use the wrist itself and go perpendicular to the tissue, and then rotate the needle around. Grab the needle with your pickups. Again, do not grasp the tip of the needle, pull that needle out, re-secure your needle driver. And as we go back into the skin for the side that is toward us, it's very important that we keep an eye on where we exited the underlying tissue on the side that is away from us, so that as we enter the tissue toward us, we are keeping things symmetrical. This ensures that the tissue will actually be well approximated, that you won't have one side being more superficial than the other, or more proud, I should say, than the other. Lots of different ways to actually tie this. You can do an instrument tie, realizing that nylon has a lot of memory. What does that mean? It means that when it comes out of the package, it likes to remember to go back how it came. And it's very slippery. So is Prolene. So are essentially all of your monofilament sutures. They are designed to essentially glide, but that gliding sometimes ensures that it's going to potentially come off of the needle driver. That was my 4th hitch, 5, and 6. Now, again, as we've demonstrated, we're going to want to cut this. So we want to come down to the knot itself, angle the hand, cut your sutures. And then you can go ahead and reload your needle for additional suturing. Again, thinking of this, now you may look at this wound and say, well, it's not exactly 15 millimeters. So I may not need 3 in this area. Maybe I would simply need 2. But you hopefully can start to picture that now you can start to divide and conquer each side, and you know that at the ends you will be well approximated. Now, do you need to suture the actual end? No, you don't. Remember that the goal of simple interrupted sutures, be it on the skin or in the fascia, is just to start to improve that overall body healing process and allow for that primary closure. If you would like to certainly do a hand tie, you can do so. And you can certainly choose to do either a one-handed or a two-handed tie. Appreciating that a one-handed tie allows for the needle to remain essentially immobile. So if you're going to do that, it's often commonplace, especially in the operating room, to grasp the needle, again, not at the tip, but grasp it along the curve of the needle and set it to the side. That's trying to help restrict the potential for injuring those around you. So I'm doing a one-handed tie. I'm doing it right-handed. My left hand is basically just keeping the needle driver down on the patient, down on the field, so that nothing is moving. And again, please try to ensure that your knots remain on the same side for your patient. It cosmetically looks better for your patient, but it also just makes it easier when either yourself or a colleague needs to remove these sutures. You would place additional sutures. I would probably place 1 additional suture here, as well as 2 on this side, and that would allow for 5 sutures total. That would be appropriate. You simply need to document this in your patient's chart. You would document both the anesthetic aspect, what you used and how much you used. You would document how you cleansed this wound and how you prepped this wound, be it with chlorhexidine initially, whether you washed it out and irrigated it with saline. Certainly, if we talk about this being a surgical wound, this is documented in the operative report by your surgeon. What type of suture you chose, how many sutures you placed, and were there any immediate complications following the procedure. From an urgent care, primary care, emergency medicine standpoint, those are the things that they look for in terms of documentation for your procedure.